year's Grumbach Award winner. And I'm sorry I can't show my slides. I'm Steve Gittleman from Pediatric Endocrinology. I just want to remind everyone who this award was named after. And this is Melvin Grumbach, who was my departmental chair when I started here a few decades ago, became a hero and research mentor to me. I just thought it was important just to remember some of the roots of our department. So he was an outstanding researcher. He made his way up the ranks. He received all the amazing accolades that you could imagine, very successful as a fellow, junior faculty member, was recruited out here to really jumpstart the UCSF Department of Pediatrics, and he really put us on the map for the department that you know today. So not only was he a superstar in his own right as a researcher, but he was an amazing departmental chair and division chief. And I think, I kind of think about the analogy with basketball, that he was the Steph Curry of his day and then evolved into the Steve Kerr of his day. And so he was very passionate about how to build the next generation of leaders. And that's in part why we've started this award. This is the 38th year of this award. And I can't show you the amazing list of people that have come before. Many of them are on our faculty and have continued to do great things. Some have left for other institutions and also have been very, very successful. So yeah, let me tell you a little bit about how we select the winner. This is really based on your performance as a fellow. So some people come in with amazing pre-fellowship training, MD, PhD, or MD, MPH, but we really focus on what you achieved during the course of your fellowship. The committee is a representative group of folks, faculty from the department that come from basic translational and clinical research backgrounds. And I must say, as the chair of the committee, it's really joyful to see how productive our fellows are, how many novel, creative research programs are evolving. And it's frankly a very difficult task to choose a winner each year because we're kind of comparing across very different types of research. But nonetheless, we have to choose the best of the best each year. So let me introduce this year's winner. That is Dr. Lauren Harasymiw. Hopefully I got the pronunciation right with her support. Before inviting her up, I will just briefly summarize her academic journey. She received a BS in biology and then an MPH in the University of Wisconsin system. Then she moved on to the University of Minnesota for medical school and pediatric residency training. And we were fortunate that she then moved here to UCSF for her neonatal and perinatal medicine fellowship. And one thing that's very inspiring about Lauren's work, she set off with a lofty goal to improve neurodevelopmental outcomes in critically ill infants. And one thing that she did was realize that she needed training across a variety of different disciplines to really approach a research question like this. So she's gone deep into biostatistics, informatics, and computational biology to get the skill set to conduct her research. Her work has been funded by the K-12 grant and has been focused on identifying alterations in brain morphology and connectivity present in infants born either prematurely or with critical congenital heart disease that persist into adolescence and are associated with adverse neurodevelopmental outcomes. So with that, I'll have Lauren come up, and I'd like to present her with her certificate, which I will be happy to hold for her. There's a cash prize to accompany this, so you guys can all join her at the bar later.
Sorry, I don't know where the photographer is. Maybe I'll take a picture. With the you want to hold it and be short? I'm not good at this one. Okay.
All right, well, thank you for that very gracious introduction and for the honor of being selected for this award. I'm excited to tell you all about the work that I've been doing during fellowship today, looking at brain dysmaturation in infants, and today we'll talk about those with critical congenital heart disease. I have no disclosures. So for a brief outline of the talk today, we're going to walk through a little bit about the clinical landscape in caring for infants with critical congenital heart disease. We'll talk about the connection between the heart and brain and how we're more and more learning that brain dysmaturation is a key comorbidity of congenital heart disease. And then my favorite part, of course, will be talking about my research, the brain as a network, and thinking about how network measures may be an emerging marker of developmental risk and resilience in this population. So advances in neonatal survival have transformed how we care for infants with congenital heart disease. About 1% of live births in the U.S., so 40,000 U.S. births per year, are affected by congenital heart disease. And 25% of those infants have what's known as critical congenital heart disease, meaning that they require a catheter or surgical intervention in the first year. And these days, early survival is greater than 90% to discharge at high-volume centers. This is data from the Texas Birth Defects Registry between 1999 and 2017, looking at 7-day survival, 28-day survival, and infant survival for all infants with congenital heart disease. And you can see, sorry, I've lost my pointer. You guys can see it? That's awkward. Okay, well, let's skip the pointer. You can see that in the most recent year, in this epoch, in 2017, infant survival for these infants was almost 94%. As infants continue to survive more and more, that's shifted the focus now to longer-term comorbidities among infants with congenital heart disease, particularly critical congenital heart disease. And we know that up to 50% of school-age children and adolescents with critical congenital heart disease show clinically meaningful deficits in attention, executive function, language, motor coordination, or social cognition. This is data from a prevalence study of a clinically referred congenital heart disease sample looking at the frequency of diagnoses across neurodevelopmental conditions. And although this data comes from a cohort of 206 patients that were referred, and therefore the overall prevalence might be slightly higher than we would expect, you can appreciate just the breadth of disorders that are represented here, from ADHD, autism, intellectual disability, learning disability, communication disorders, and developmental coordination. So with this increasing focus on survival and the long-term outcomes in these patients, we're more and more realizing that a core target of congenital heart disease care should actually be neurodevelopmental outcomes, now equal in priority to survival. This is a quote I really appreciate from a 2024 American Heart Association risk framework, saying that risk-stratified neurodevelopmental surveillance beginning in infancy is now a standard of care. But how exactly do we do risk-stratified neurodevelopmental surveillance in these infants? What are the causes of their neurodevelopmental outcomes or challenges that they may have? And that's quite a complex question. This diagram here summarizes some of the impacting factors for neurodevelopmental outcomes, certainly not all of them. But we can think about 3 big categories, looking at an infant's brain development, the risk of brain injury, and then the social and educational factors that form the environment that they live in. We're very lucky here at UCSF that we have a talented group of researchers that have been studying these questions going back now over 20 years. And I've summarized our current cohort of investigators, although there are so many more that I couldn't fit them all here on the slide. And I was fortunate enough to come and work with this group, the Pediatric Heart Brain Research Program, when I started fellowship, to study these questions, looking at how brain development and brain injury in children with critical congenital heart disease shapes their neurodevelopmental outcomes. This work started about 20 years ago with the development of a prospective cohort study of these infants. And although it's changed over time and grown, the core idea has been to follow these infants from birth into adolescence and track both their brain development and their neurodevelopmental outcomes. This is sort of the current schema of how the study works, where we start by enrolling patients in the prenatal period. Many get a fetal MRI. We then follow them into the neonatal period, where they get a preoperative and a postoperative MRI surrounding their cardiac repair. And then post-hospital discharge, we follow them initially in early childhood for developmental follow-up, and then into school age for advanced neuropsychological testing and MRI. And I just want to highlight 2 of our families here were gracious enough to provide pictures of their infants showing the impact that they have in our research. So from this study, this prospective longitudinal cohort study, we've been able to advance our understanding of brain development and patterns of brain injury in this population. Really understand that the connection that takes place between the heart and the brain. I'm going to take just a few minutes here to highlight some of the important advances in the field, although I certainly don't have the time to cover them all. So one of the first important advances from this cohort study was understanding just the scope of acquired brain injuries. These are extremely common in congenital heart disease. The 2 most common patterns being white matter injury and strokes. And you can see here imaging on the left of a multifocal white matter injury shown on T1 and diffusion, and then on the right of a MCA distribution stroke shown on T2 and diffusion. In the early years of our cohort, we saw that preoperative brain injury was present in about 40% of these infants before they even went to the operating room, and about 1/3 of infants had new acquired injury after their cardiac repair. We've seen now in more recent epochs in our cohort that some forms of post-operative brain injury, particularly white matter injury, are declining, but the rates of preoperative injury are still high. And one of the important factors that contributes to the risk for brain injury in these infants is just their abnormal brain development. So we know that term newborns with critical congenital heart disease have brain abnormalities similar to preterm infants. I'm sorry, this graph is probably showing up a little bit small, so I'll just walk you through it. So this was work done by Patrick McQuillan and Stephen Miller back in 2007, published in the New England Journal of Medicine, where they showed across multiple markers that term infants with congenital heart disease had markers more consistent with preterm infants. And that included both markers of important brain metabolites on spectroscopy, shown here on the top, and then also on diffusion imaging, looking at maturity of the white matter. This delayed brain development in congenital heart disease actually begins in the 3rd trimester. So this is data from Kathy Limperopoulos and her colleagues looking at total brain volume here across gestational age in a set of healthy controls and fetuses with congenital heart disease. And you can see the decreased growth in total brain volume that's happened starting at about week 28 up until term. And this makes sense when we think about how normal brain development progresses in utero. During the 3rd period, during the 3rd trimester, there's a period of rapid brain growth, and the heart responds to this by increasing its cardiac output. However, we know that oxygen delivery to the brain in congenital heart disease is impaired. So shown here in this figure, we have normal fetal circulation on the left, an example of 2 critical heart lesions, transposition of the great arteries, and hypoplastic left heart syndrome. You can see that not only are infants more hypoxic, they may also have a decreased volume of blood delivered to the brain. And researchers went on to show, this is work done by Sun and colleagues, that oxygen delivery and consumption are associated with fetal brain growth. So this is shown where we are correlating brain size with both the ascending aortic oxygen saturation, which is our curve on the bottom, and cerebral oxygen consumption, which is shown on the top. So as oxygen consumption is decreased, so does total brain volume in fetal growth. And these differences to fetal brain development continue in the postnatal period and are particularly associated with chronic postnatal hypoxia. So this is work again from our cohort done by Shabnam and Payavande, published back in 2018, that compared two key groups. So these are infants with either detransposition of the great arteries who get a definitive surgical repair in infancy and therefore experience normoxia after that point, and those with single ventricle physiology, such as hypoplastic left heart syndrome, who go through a staged palliative approach and end up with a period of prolonged hypoxia. Dr. Pavandi showed nicely here, and sorry, I can't see my pointer here, in these 4 graphs here looking at total brain volume, gray matter, white matter, and deep gray matter. And how you can interpret these graphs here is on the axis here we have gestational age that the MRI took place, and then the brain volume that we're mapping. So babies from our cohort are shown on these graphs with either 1 or 2 data points, depending on how many MRIs they completed. You can see for the infants in transposition, who are shown in orange, their velocity of brain growth is higher than those with single ventricle physiology. And this is even more pronounced when you look at white matter and deep gray matter, suggesting that those infants who remain hypoxic experience a slower growth in their brain volume. Dr. Pavandi also showed that those infants who have brain injury are also at risk for delayed brain growth. So this is again showing gray matter on the left and white matter on the right, and comparing those infants with no brain injury in blue to those infants who had moderate to severe white matter injury, grade 3 plus IVH, or a hypoxic ischemic injury, showing particularly for the white matter here, a significantly slower rate of growth among those infants with brain injury. So we know not only do our infants at risk for brain injury because of their abnormal brain development, but that brain injury is then associated with ongoing differences in how their brain develops. So in summary, what we know about brain dysmaturation and congenital heart disease, that neonates with congenital heart disease are at risk for brain injury. Term neonates with congenital heart disease are born with immature brains. Their abnormal brain development starts already in utero and raises their risk for brain injury after birth, and that neonates continue to experience slower brain growth, particularly in the setting of prolonged hypoxia. So we know quite a bit about how the brain grows and how the volume of the brain is impacted by congenital heart disease. But what we know less about is how the brain functions. So underneath the structures of the brain functions as a neural network. And that network formation, we're just beginning to understand how it may be impacted by congenital heart disease. So this brings me to the second part of my brain, or I'm sorry, the third part of my talk, thinking about the brain as a neural network. So the wiring of the brain's network, although it's also known as its structural connectivity, develops rapidly across the perioperative period. And it may be uniquely vulnerable in infants with congenital heart disease. The architecture of the brain's network is made up of cortical hubs, which are key regions that act as central connections by integrating and facilitating communication between different brain areas and networks. And the connections between those cortical hubs are formed by the brain's white matter tracts. The wiring of the brain's network develops rapidly during the early 3rd trimester, even before the baby is born. From the early 3rd trimester to term, both the density of the cortical hubs and the intricacy of the connections between those hubs increases significantly. Overall, after birth, the integration of the network continues to increase while the segregation of the network decreases, meaning that the brain gets better at passing information across the whole brain and doesn't rely as heavily on retaining information connections within specific regions. So when we're talking about the brain network development, what we're really talking about is how efficiently these regions are being connected. This is data that came from a study using diffusion magnetic resonance imaging, or DMRI, in 25 neonates, 13 toddlers, and 25 adolescents, looking at network dynamics across these 3 age groups. On the left, you can see there are 2 markers, global efficiency and local efficiency, which are markers of the network's integration. You can see that these steadily increase from the neonatal period in green to the toddlers in blue and the adolescents in purple. In comparison to this, markers of segregation in this graph, small worldness and normalized CP, decrease from the neonatal period down to the adolescents. So this network formation is what I set out to study during fellowship. And specifically, I wanted to ask the question of whether perioperative brain MRI can identify which infants with critical congenital heart disease are at greatest neurodevelopmental risk using markers of brain network development. So the work that I've been doing has been divided into two parts. First, looking at neural network development in these infants using neuroimaging and asking the question, does cardiac lesion impact brain network development across the perioperative period? And along with that, is network development impaired after acquired brain injury? And then the second phase of the work that I've been doing is looking at neurodevelopmental outcomes and asking whether we can use perioperative network brain development to predict neurodevelopmental outcomes in these infants at 1 to 3 years. Data from my work has come from the same prospective cohort study that I described in the beginning. For this particular analysis, we used infants who were enrolled either in the fetal period or the very early neonatal period. They then all had a cardiac repair in the neonatal period, and most had a preoperative and postoperative MRI that were completed. Preoperative MRI happened around day 5 of life, and on average, the postoperative MRI happened on day of life 25, so about 3 weeks later. We then used neurodevelopmental follow-up data from these infants that was collected in early childhood at 12 months, 18 months, and 30 months. And for the purposes of this analysis, we excluded infants who were born premature, less than 36 weeks, had congenital or genetic anomalies, or who had no postnatal repair. So overall, there was a sample of 117 infants who fit these criteria. Study period ran from November 2011, which was the start of 3T MRI imaging here at UCSF, and continued into January of 2025, with a follow-up period extending to June 2025. Of the enrolled subjects born during that period, 83% had DTGA, or single ventricle physiology, and received at least one MRI. And from these 97 babies, there are 170 MRI scans conducted during the perioperative period. Unfortunately, we had to exclude about a third of those scans just due to post-processing or analysis issues. And overall, that left us with a sample of 43 paired preoperative and postoperative connectomes. And of the 43 subjects with complete connectome data, 74% had follow-up at least one time point. So in the first part of the study in our neuroimaging, we used T1 and T2 images to score for the presence of brain injuries. So this would be white matter injury or stroke, like I showed you in the initial slides. Then used diffusion tensor imaging to create a whole brain structural connectome to reflect the white matter tract connections in the brain. And finally, used linear mixed methods to test the effects of cardiac lesion and brain injury on the trajectory of neural network development. Just going to briefly walk through this neuroimaging analysis so you have a sense of the data that we're looking at here. In this process, we start with structural images from T1, and we register those to a neonatal atlas in order to define anatomical regions of the brain. And those anatomical regions become the nodes of the network that we'll assess later. We then do deterministic tractography in order to represent the white matter tracts, and those white matter tracts create the network edges in our eventual network. This forms a weighted undirected adjacency matrix between each of the 90 regions of interest, divided between the frontal, limbic, occipital, parietal, deep gray, and temporal lobes. And then from that matrix, the connectome patterns are described using topological metrics from graph theory, which is a form of mathematics. So from there, we can measure properties of the network looking at things like efficiency, transitivity, and modularity, which are measures of integration and segregation of the network. So overall, data from a total of 97 neonates was included in this analysis. Both groups were majority male and had slightly less than half identified as Hispanic and Latino. Infants with single ventricle physiology were born slightly earlier, had a slightly higher SNAP-2 score, which quantifies illness during the immediate postnatal period. They were less likely to need a septostomy compared to those with DTGA, and they had slightly longer length of stay overall. So the first question we wanted to ask with this data was whether or not cardiac lesion impacted neural network development. And I'll take a minute here to walk through these graphs quickly because you'll see them through the rest of the presentation here. So on the left here, I'm looking at network integration using global efficiency, which is one of our graph metrics of the network integration. Along our axis here, we have postmenstrual age. So this was the time at which the MRI was completed. So again, most of these infants have 2 data points that are represented on the graph for a preoperative and a postoperative MRI, while some infants are represented only once, depending on what imaging that they had. And then you can see the trend line representing the group estimate for their trajectory of development across the perioperative period. So on the leftmost graph here, I'm looking at neural integration through global efficiency. And on the right, I have 2 markers of network segregation, known as transitivity and modularity. And what you can see from these 3 graphs is that for both groups, DTGA and SVP, all infants showed increases in their network metrics during the perioperative period. What we don't see are statistically significant differences between the rates of development by cardiac lesion. Although you see perhaps a suggestion in network integration, a similar pattern to what we've seen previously in our brain volume data, where the single ventricle physiology patients had a slightly slower rate, although this did not reach statistical significance. So from here, we went on to ask whether perioperative brain injury instead was impacted by neural network development. So overall, the rate of brain injury in this sample of infants with critical congenital heart disease was fairly high. About 45% had an injury on their preoperative scan, and 35% had a new injury on their postoperative scan, consistent with our cohort overall. The most common form of injury was white matter injury, which was more frequent on the preoperative scan than the postoperative scan, although this difference didn't reach statistical significance. And stroke was overall a rare event, with about 10% of babies having any form of stroke, either preoperatively or postoperatively. So we first looked at whether perioperative brain injury any form of brain injury was impacted by neural network development. So these are the same graphs that you saw before, looking at measures of network integration and network segregation. And now our 2 groups that we're comparing are in green, infants who had any form of brain injury, with infants who had no brain injury in green compared to infants who had any brain injury in orange. And what you can see is when it comes to their measure of global efficiency, which again is that network integration or passing information around the brain, the trajectory of development shown in green is significantly higher for those infants who had no brain injury. So knowing that brain injury was impactful, we wanted to go on and ask whether there were specific forms of brain injury that had the most effect on neural network development. So I repeated this analysis focusing only on white matter injury. So in these graphs here, you can see that the infants in purple had no white matter injury, and the infants in green had white matter injury specifically. And again, we see statistically significant differences in the rate of development in network integration on the left. I also see a fairly large qualitative difference in network segregation in modularity shown on the right. Although this didn't reach statistical significance, and it's worth noting that the measure of modularity overall is much more difficult to measure and has a higher sort of dispersal rate compared to global efficiency, suggesting there may be a sample size issue here, which is not allowing us to reach statistical significance. And then finally, we went on to look at stroke. And again, for stroke, you see that babies who had no injury or no stroke had a faster rate of network integration. However, again, this did not reach statistical significance. In this case, most likely because stroke is a very rare outcome in this population, with only less than 10% of babies actually having any kind of stroke. However, there is no impact on network segregation with transitivity or modularity, which, when you think about it, could make sense. A stroke takes place in a very isolated part of the brain, usually, and global efficiency is looking information transfer across the brain, versus measures of segregation are looking at whether information can be well passed within specific regions of the brain, and are less likely to be impacted by a focal injury. So knowing that we saw differences in network development present with some forms of brain injury, we wanted to go on and ask about how this might be affecting infants' neurodevelopmental outcomes. And to do that, we used a joint modeling approach. I know not everyone loves statistics as much as I do, so I'm going to summarize the slide very briefly to say this is a approach we use to deal with some of our missing data as well as our repeated measures, where you essentially conduct two models. Your first model, you model how network development changes with age. And for each infant, you can extract their own baseline and rate of change. So essentially their own slope of development in your metric of interest. And then you can use that slope to then predict their neurodevelopmental outcomes. And in this case, we use Bailey scores that were conducted at 12, 18, and 30 months. So we're also repeated measures. So our second model accounted for that repeated measures design, allowing us to sort of maximize our outcome data. So this just shows you how our Bailey scores are dispersed by domain and by age. So on the left here, we have cognitive scores for our sample from 1 to 3 years. And you can see the two dotted lines. Sorry, I've lost my pointer again. There we go. So here's our population average, and then our lower line here, below this line are infants who are at risk for developmental delay. So although most of our participants are clustered around the population average up here, there's a not inconsequential portion of our participants who are at risk for developmental delay when it comes to cognitive, language, and motor scores, with a few infants in particular having quite severe deficits noted. So we use these measures as outcomes in our model looking at neural network development as a predictor of neurodevelopmental outcomes. So I'll go over each of these individual models. And the way to interpret this data here is, so our global efficiency is our exposure of interest, looking at the slope of the global efficiency as it predicts cognitive scores, language, and motor scores. And so our estimate here of 8.21 means that for every 1 standard deviation increase in the slope of global efficiency, the Bailey scores were 8 points higher overall for cognitive scores, 9 points higher for language scores, and 5.5 points higher for motor scores. And this was after we already controlled for differences in brain injury, important socio-demographic markers like maternal education level or the Childhood Opportunity Index, which is a neighborhood level metric that are known to be associated with neurodevelopmental outcome differences, as well as cardiac lesion, and then some of our assessment issues, knowing that our assessments occurred at different ages and across different Bailey scales additions. So it's important to note that this relationship between neural network development and neurodevelopmental outcome measures holds after these important corrections. And this is really the first time that we've been able to see a neuroimaging marker that was significant for cognitive outcomes in infants with critical congenital heart disease in particular. And you might wonder, okay, 8 points on the Bailey scale, what does that really mean in clinical practice? So when we compare that to other markers such as maternal education, which has been shown between maternal high school versus graduate education to have an 8-point difference in cognitive scores, looking at low versus high SES quartile, shown to have 7-point increase in Bailey, or comparing extremely premature infants with term infants who have a 7-point increase in Bailey scores. But the difference we saw here with our neural network metrics is actually fairly significant. So in conclusion, my work shows that cardiac lesion alone, just categorizing by single ventral physiology or detransposition of the great arteries, did not significantly predict the trajectory of perioperative brain network development. In contrast, we saw that brain network development was significantly slower in infants with white matter injuries. And this is consistent in some ways with past work done looking at brain morphology, which did show slower brain development in the presence of white matter injury. But it does show an interesting story potentially for resiliency among those infants who have chronic hypoxia, where although they may be experiencing slower growth in the volume of their brain as they develop, the network development that's taking place underneath is preserved. And most importantly, how an infant's brain network develops perioperatively is a strong predictor of early neurodevelopmental outcomes, particularly cognitive and language development, which we don't have good predictors for in this population, particularly from neuroimaging. So what are some of the implications of this work? This is obviously still very early on, but it's important to recognize that neuroimaging neuroimaging is an important component of intensified developmental surveillance for these infants, irrespective of their cardiac diagnosis. And in particular, longitudinal neural network metrics may be meaningful biomarkers for risk stratification. It certainly might be a bit of a lift to ask us all as clinicians to put our babies in the scanner multiple times during a very acute illness period. But I think what this study shows is when you take that type of effort, you can extract meaningful information from neuroimaging, which can help families understand what might be happening in their children's future. Of course, there's many limitations to this work. In particular, it was a single central, and we looked at a narrow perioperative MRI window. However, that just opens up the avenues for so much more work that I'm excited to do from here. So what's next? I've looked at whole brain neural network development and how it impacts early childhood outcomes. From here, I'm very interested in looking at how clinical factors during the neonatal period impact this network development. So this could include more refined measures of cardiac physiology, looking beyond just lesion type to look at actual metrics of hypoxia and blood flow in these infants. Looking at quantitative brain injury mapping, so not just the presence of a brain injury, but where that brain injury is and the amount of tissue it's impacting. The maternal fetal environment is incredibly impactful when it comes to brain development, looking at things like placental dysfunction and premature birth. And then most interestingly to me is the opportunity for neuroprotective clinical care and understanding what elements of the care that we give to infants is actually aiding their brain development. We also, in this initial work, only looked at the whole brain network development, but there's multiple additional analyses that can be conducted, focusing either on specific white matter tracts themselves or looking at network development in specific regions, particularly regions we know are impactful for different outcomes. And then finally, since we're gifted with an extraordinarily longitudinal cohort, there's increasingly the ability to look at neonatal markers as being predictive of outcomes in the school age years, so from 8 to 18 years, both when it comes to their brain development at that time and their cognitive and functional outcomes. And with that, I'd like to just take a minute and thank so many people who have been a part of this work and a part of my fellowship journey. In particular, my mentors, Patrick McQuillan and Shabnam Payavande. I first met Patrick when I interviewed for fellowship here, and I was so struck by the breadth and depth of what he had done in his career and what had been accomplished studying the baby brain here at UCSF that it's really what brought me here for fellowship. And after I came to UCSF, Patrick introduced me to Shabnam and their partnership in the pediatric heart and brain research program. And having them together as dual mentors has just been so impactful for my career development, particularly Dr. Payavande, who as a female physician scientist has just been an incredible mentor and inspiration for all of the things that she has accomplished here in her career. I can't name all of our collaborators by name in the time I have, but I really want to call out Amy Kwang, who's our research assistant, and Duan Zhu, who's who works with us on all of our neuroimaging, who I possibly could not have done this work without. Our collaborators at University of British Columbia and Sick Kids, the dyslexia group here at UCSF, all of my funding, and then also the Division of Neonatology, and in particular Luke Judge, who leads our fellowship program. The Neonatal-Perinatal Medicine program here at UCSF is really the preeminent program for developing neonatal physician scientists. And I have just been so blessed to learn from this program and to grow as a physician scientist during my time here. And it really would not have been possible without Luke's really tireless advocacy for our program and our fellows. And then finally, I'd really like to thank the Physician Scientist Development Program, where I've been funded through a K-12, and particularly Sally Premar and Alex Basuk, my steering committee mentors. I think many of the people in this room have been impacted by the changes in the federal landscape over the last year. And the PSDP in particular had a very challenging period last spring where the grant was temporarily canceled. And I had so many conversations with Sally and Alex that were so helpful in just reminding me during these challenging times how important it is to keep your eyes on the work and to keep moving forward and let things work themselves out for you. And I really find that to be true. So thank you again to everyone for listening to me today, and I'm happy to take any questions.
Yeah, please, let's have some discussion. I'll try and to pass the mic around. I think there are people on Zoom, so let's make sure they can hear things.
Great talk, Lauren, and great work in general. Oh, I have a very specific question about the post-operative MRI for the babies. Are those all feed and swallow, or do some of them get anesthesia?
Yeah, so keeping in mind the cohort spans 20 years,
Right.
the initial infants in the cohort, they most all were sedated with phenobarb and were intubated. However, for this analysis, almost all of these babies were feed and swaddle, both pre-op and post-op. Sedation is only given when it's clinically indicated, which it's the minority of the scans. I haven't looked closely at the number, but most are feed and swaddles.
And the related follow-up, because you said, it's a relatively narrow time frame you're looking at. So ideally, how far out would you go for this, for the imaging?
Yeah, so as I'm sure many know, it's quite hard to do a feed and swaddle MRI in an infant over about 8 weeks life. So as much as I would love to get an MRI at like the 3 or the 6 month mark to capture what happens once the infant reaches the home environment, like that would be the ideal, right? To know what happens inpatient and then outpatient during that early period of rapid development. I think I proposed that as one of my K-12 or K-23 aims at one point, and Patrick helped me rethink that approach. So there's technical limitations there that I think prevent us from really being able to do really quality longitudinal imaging. But I think the way that we target our preoperative and our postoperative and what we've done previously with premature infants does a nice job of capturing the perioperative or the postnatal period in these groups. And I certainly don't want to discount the impact of the home environment. But I do think it's important to consider what we can do when these infants are still admitted. This is a time when they are solely under our care, and we can really make the most of the care that we give them to try and improve their impact. So that's the window I want to really focus on.
Other questions? Maybe I'll ask a non-neonatologist question. I think you were careful to say that the infants you studied were all term infants who had congenital heart disease. How often do kids with congenital heart disease go to term versus preterm?
Almost all of these infants are born around 39 weeks. The majority go to term. We do have a sort of a sister project looking at premature infants who are born with congenital heart disease. And I was just actually looking at these admissions data recently. It's about maybe the numbers are about a third of the preemies of what there are on term kids. So most of them are born right at term.
Yeah. Other questions? Here we go.
Congratulations on the award and wonderful work. I have 2 questions. So you talked about global connectivity. Can you speak maybe a little bit about if there's heterogeneity in connectivity and how you might look at that, and if you might expect to see differences in this cohort?
Yeah, that's a great question. So I'm working on this analysis right now that sort of looks at this from a backwards approach. We're taking the infants who had abnormal measures on their Bailey and then looking backwards and saying which specific connections in their brain are either downregulated or upregulated relative to those infants who don't have those neurodevelopmental differences, and trying to identify almost more like a phenotype of brain dysmaturation. There have been other studies who have done sort of similar approaches, and the findings are sort of a little heterogeneous. There's a little heterogeneity there. So I think there's a lot of work still to do in that area. But ultimately, the goal would be to sort of create these phenotypes of brain dysmaturation that really sort of describe comprehensively how brain development is impacted in both by an infant's physiology and their clinical course.
Yeah, so that actually dovetails into my second question, which is you did a lot of really careful work to make this beautiful cohort. And I'm curious if you went the other way with all the imaging and included things like prematurity and the genetics, whether you might see some segregation in those respects.
Yeah, so I think a little bit of what you're getting at is one of the outshoots of this work is doing predictive modeling, where we're trying to bring together a really comprehensive set of neuroimaging metrics from multiple forms of imaging and put that together with clinical factors, sociodemographic factors, genetic factors, and use that with machine learning to then predict outcomes at like the 4-year or the 8 to 18 year, where we can really start to get more advanced neuropsychological profiles. Try and put that all together, because ultimately the answer for risk stratification isn't just neuroimaging or just cardiac lesion or just prematurity. It's putting that all together and trying to come up with models that can predict more individual risk for each baby.
Hey, that was amazing, Lauren. My question is about the neurodevelopmental outcome domains, and I think that there were some differences, and then different, like age was also a component of that. And I mean, what do you think explains that? Is it just the complexity of those particular areas, or do you think there's other things that potentially explain those trajectories, I guess is.
There's definitely unexplained variance in this model, I would say. So there are aspects that are contributing to development that we're not fully capturing in these particular models. Some of the factors that from other studies we might be suggested to be impactful, things like maternal education level, it was included in all of these models, but it's actually not significant, which is interesting here. And it may be that part of that is because we are controlling for the neuroimaging marker that's more significant. Some of the differences between the models, like for example, the cardiac lesion is only significant in the motor scores, and that's something that we've seen previously. And I think in that particular case, kids with single ventricle physiology tend to have a longer hospital stay, and that hospital stay really is associated with early deficits in motor outcomes that tend to decrease over the course of childhood. So some of it is just the complexity of what we're trying to measure.
I think we might have a firm stop. Is that what I'm hearing? Yes. Why don't everyone come and track down Lauren afterwards here? Congratulations, beautiful talk.